Yeah, it's very painful to give a talk after Maya, but we'll do it. So I will talk about adaptive designs. I think Maya made an excellent presentation making the case that we can utilize randomized trials or observational studies in a much better way than currently done, in the sense that we can answer very complex questions such as what is the optimal rule for allocating treatment, and then even not just learning that, but also actually evaluating how well you can do relative to something else. So that's very exciting. So what I want to talk about in this presentation is what we call adaptive designs, and I'm talking about a particular type of adaptive designs where we are going to assume an ordering of subjects, and it might be groups which enroll at different times, or maybe subjects enroll continuously in time. And where we're going to say, you know what, the subject comes in, before I make my decision of how to randomize this subject, why am I not looking at all the past data so far and learn from that? And then decide how to randomize your treatment. That's an example of an adaptive design. I'm going to talk about advances in that. And before we do that, I just want to point out there is actually a completely general statistical approach which attacks any of these type of formulations of designs. So in other words, there's immense room for creativity, where you can just sit down and have crazy ideas like Elvin has all the time. And then, once we can agree on how we are going to exactly do this, how we're going to adapt our design, what kind of adaptations we are looking for, we can work out, go through this roadmap, which is essentially saying, okay, you described for me the kind of experiment you want. Essentially, we will have data like O1 up to ON on n subjects. That has a sort of probability distribution, right? That's what statistics is all about. We then say, what do we know about that probability distributions? Now, for example, we might know the randomization probability, right? Because that would be the case in an adaptive design. But maybe other things we wouldn't know at all, right? So we wouldn't assume anything like a parametric model. And then we define the query about this experiment of interest, and that gets to the kind of questions like Maya talked about, where we say, hey, I care about whatever it might be, the mean outcome under an optimal dynamic rule. Once we agree what the query is, we want to ask about our data distribution, then we have to a priori define an estimator, and that estimator, we have to analyze that. That needs to have a nice behavior, a so-called sampling distribution. It needs to be somewhat normally distributed and relatively unbiased and all that. There's a general approach for developing these estimators, what we have been working on for 10 years or so, which is called targeted learning, which really follows this roadmap, but does recognize that all this kind of assumptions which are realistic will not specify the data distribution up to like a regression, a set of regression coefficients. So we really have to learn a lot through machine learning. We have to learn relations between the outcome and the treatment and the characteristics of the patients and so on. So that's one thing we have to do. We can utilize the state-of-the-art in machine learning through ensemble learning, where you get all the best algorithms in the world together, including your favorite parametric models, and then use cross-validation to decide which algorithm works best, or even which combination of algorithms works best, and that's called super learning. Not only because of the theory, which says that this is actually the way to go. You will do S well with asymptotics, and also in finite terms you often see that S, the oracle choice, which is, if you know the truth, you know which algorithm does best. That's not enough, because that just learns the relevant relations in your data distributions, but at the end of the day they are mapped into that estimate which represents your scientific question of interest. And for that, we have to target the fit towards that question, and that's called target maximum likelihood estimation. And that again follows a mathematical roadmap which we can work through, and then develop these so-called targeted machine learning algorithms which are tailored towards your very question of interest. And because of the targeting, we actually do get inference, we do get a normal distribution and all that. This was one of the big problems in machine learning. They didn't have inference because when you just do the machine learning, it doesn't work. You don't get these kind of properties. So the targeting makes it work. So you can think of targeted learning as a field which takes all the advances in deep statistical theory, machine learning, and the causal modeling, defining the scientific questions, put it together in a machinery, utilizing them all to get these answers. For people who are interested, there's a recent book out and also previously on this topic, and many contributions from all kinds of people. Okay, so just as an example, let's look at this. Is from Romain Peraccio. So he was interested in the question, if you treat sepsis patients, should we just give them antibiotics or should we also add a steroid? The medical community thought that the steroid was important, and so they started running randomized trials to evaluate if it works. In the end of the day, they did 31 randomized trials, and they couldn't conclude anything. It was kind of confusing to them because they thought biologically this made perfect sense. Okay, so Romain Peraccio, educated in target learning, said, okay, why don't I reanalyze these trials with actually these more efficient approaches, targeted learning approaches, which really utilize machine learning, learn these instead of not using all the covert information about the patients, actually utilizing it to really get much more efficient estimator and still completely robust because of the randomization. So he did that and he found a significant result. But you could also say, what was going on here, right? And if you actually analyze the data, you could have said, a la Maya, you would have said, okay, why don't we go for the optimal rule? Why don't we use this data in the randomized trial and try to estimate what is the best rule for treating? And what you would have found is that there is this single binary variable, which is the effect heterogeneity of the response by ACTH stimulation. If you are a responder, this is actually bad to add the steroids. If you're a non-responder, it is good. So there are actually these. So one simple rule would simply take that into account and do the right thing for every person. So this is a way it could have been analyzed. Even after a few randomized trials, they might already have nailed this, and everything would have been fine, and we would have learned the right thing instead of spending another 30 randomized trials. But this also raised the question: why are we not learning, right, sequentially? If we have a whole sequence of randomized trials, maybe we should start paying attention what was learned from the last trials. And what is there? All the data. And so that asks you then the question, why can we not run, I'm just going to talk, so don't read the slides. Why are we not going to do a group sequential randomized trial? Think about the sepsis, right? You randomize people, like a few hundred patients, to one of these drugs. Let's say we flip a coin with probability half. After a month, we have the data because it's a 1 month outcome. It's very fast because people either die or not. You then have that 200 patient data, and you say, let me now use some machine learning to learn what's the best treatment in response to the characteristics of the person. No, you might find something, right? You might say, hey, it looks like maybe this binary variable, like the one I mentioned, or maybe something else, is actually making a change. But you also look at the uncertainty in these estimates, and so based on that, you create randomization probabilities, which are not half-half anymore, but are more moving towards what there seems to be evidence of, based on analyzing the past data with respect to the conditional treatment effect. Okay, so now we flip a coin with probabilities depending on the characteristics of the person, but still known probabilities, more moving towards what there seems to be evidence, what the evidence is suggesting. So now after another month, we have 400, because we randomized 200 patients, we have 400 patients. Let's do this again. Let's now use all 400 patients to analyze what's going on and what is the best treatment allocation rule. Now we get more evidence because it's more precise, the confidence intervals are smaller, and so our randomization probabilities are starting to move towards more deterministic assignment. And so we go on. Right? And of course, at any point in time, we can actually say, let's analyze the data, let's decide if this optimal treatment we have learned so far, the estimate of it, is that making a difference relative to control? And that works, and we have the estimators for that. This is actually an example of a very famous contextual multiple bandit problem in computer science, which people have been working on for decades, and still it's very actively used, these kind of trials in places like Facebook and whatever, Google. Not so much yet in the medical community, but there's absolutely no reason why not. And in fact, we developed the theory so that this is now completely robust. In the past, in past literature, people really focused on parametric models, developing the theory. When you assume parametric models, the FDA is not going to like that because these parametric models are wrong. They assume simplistic relations which are false, and so you cannot trust the results. In our case, our results are completely robust, as robust as your simple randomized trial where you go after the average treatment effect with flipping a coin. All we need is to know these conditional probabilities. We don't care that they are changing, and depending on the characteristic of subject, everything works beautifully. So there is absolutely no reason anymore to not do this. Okay, so now, since I started teaching adaptive design this year, you start thinking about the limitations of what's currently have. Like this kind of thing I think is reasonable for the sepsis trial, but if you look at the kind of designs we're talking about in implementation science, we might want to follow people up for a year. Maybe after a year we decide if we have succeeded in keeping people in care. So an outcome on a subject actually takes a year. So we cannot do a group and then after 1 year say, okay, analyze and then do the next group. That takes a long time, right? And your trial will last too long. That's one of the reasons why adaptive designs haven't been that popular for many cases. However, there's absolutely no reason why we cannot do the following. If we have a continuous enrollment of subjects, right? Subjects come in, maybe first a group, and then they enter in at different times. What you can do, the moment a person comes in, right, like maybe 4 months in the trial, you say, okay, what's the data I have so far? Now, if let's say this guy might be number 120 enrolling. That means there are 119 patients beyond him which we have been following up, till different degrees. Some have been followed up for 4 months, some have been followed up for 1 month, 2 months, so on. So why are we not using that data, even though it's not complete records, because none of them have been followed up a year, and try to learn from that? And try to learn in the way that you say, okay, what about looking at surrogate outcomes? Right? If we are, for example, with keeping in care, right, Maya pointed out the perfect surrogate outcome. How have you been doing so far about keeping these guys in care? So if you have a 4-month data, why can we not use, like the 3-month surrogate outcome? Are we doing well up to 3 months? And find out the optimal treatment rule for keeping people in care, at least in that short amount of time. Right, so in this way you can start adapting your randomization probabilities still, but now with respect to surrogate outcomes. And the whole theory, except I still have to work it out, but in my mind, the whole theory will carry through and it will all work beautifully. So these are things we can do. We just need people to actually say, yeah, that's what I want to do, right? And then we can do it. Okay, so I'm going to stop. The other thing I was maybe potentially going to talk about was, for example, what we can also do is sequentially randomized trials within a single person or within a single unit, right? You can actually do experiments, like you can randomize yourself every day, look at an outcome the next day, and do adaptive designs in that way. That's also possible, even within single people. But of course, now it's asymptotics in the number of time points. So but these are just things to keep in mind. Also available, also something we can do. Quite exciting. So I'm going to stop there. The conclusion is the group sequential randomized trials can be used for short-term clinical outcomes. They're adaptive, like the sepsis one, but for sequential randomized trial adapting in continuous time, we will take into account surrogate outcomes. Again, we can do that. And all of these trials are completely robust. So there's no argument, even though we use machine learning, right? Everything is completely robust, it's unbiased, it gives you valid confidence intervals. So there is no argument about, that we have to simplify things. So thank you very much.